Good morning. Good morning. Good morning. Good morning, everyone. Good morning. Hello, and welcome to the 6th Annual Room to Grow Journey to Cultural and Linguistic Competency. This is coordinated by the Center for Diversity and Public Health Leadership Training at the Kennedy Krieger Institute. We were formerly known as the RISE programs. So I'm Dr. Harolyn Belcher. I'm the director of the center and associate director of the Leadership Education and Neurodevelopmental Disabilities program, fondly called LEN program, and I welcome you. And I'm hoping you're enjoying the scenes that we have up. I actually had the opportunity to take an early tour of the National Museum of African American History and Culture, which opens to the public this weekend, and I highly recommend that everyone visit. It was awesome and powerful in both the content and the structure of the building. It's just fabulous, fabulous. So today we have an equally awesome and powerful group of speakers this morning, and for lunch we have this interactive discussions in the afternoon, which will resume at noon for lunch in Finestone in the School of Public Health. So we'll lead you over there, and then we'll have separate sessions where we have our scholars, our trainees, early clinicians in the Finestone, and the older clinicians, probably that's me for one of the speakers, clinicians in room W5008. So more instructions on that to come. So hold on just a second. I should say we should turn it off, right? Yeah, we should turn off our speakers. So where was I think. So first things first, I really would like to thank everyone of the center, so particularly Dr. McFadden, Dr. Stone, Jamie Hickman, and Shante Johnson, who really were our infrastructure in helping to make this happen, but also the sponsors of the conference so that we can offer this to you all free of charge and giving you 5 continuing education credits for those of you who can use those. We are especially grateful to the Office of the Provost from Johns Hopkins University, the Maryland Center for Developmental Disabilities, the Hopkins Center for Health Disparities Solutions, the Johns Hopkins Department of Pediatrics and LEA program, the LEN program, the Bloomberg School of Public Health, in health populations, family and reproductive health, and the DC Baltimore Research Center on Child Health Disparities. All of these have helped to make this available for you. So our theme this year is race in the United States in our healthcare work, the work that we do. So it's important to note that we at the center see race as an important social political construct, not biological. In fact, there's more genetic variation among African people than there is between African, who we call African Americans or black folks, and white people. So we are really much closer genetically. We are all part of the human race. So, but there are some social political implications to what we call race that makes a difference in our health equity and our health disparities. So this is what we want to address, we want to learn more about, so that what I tell my students is we want to eliminate socially determined health disparities within one generation. So we want to eliminate that within 25 years. And these are socially determined factors that you all have a very important role in addressing, identifying, and eliminating as far as research and policy. And so these are the reasons that these speakers are here to talk to us about some of these factors in a solutions-oriented way. So first, however, I'd like to introduce Dr. Tina Cheng, who is the new director and Given Foundation Professor of Pediatrics, and she will give a welcome. So thank you.
So good morning. I really wanted to congratulate Harolyn and her team for an incredible program today. This is the 6th annual Room to Grow conference, and for those of you who have attended in previous years, you know that it's an exciting day each year that this has gone on, and I'm sure with the speakers that are in line for us today that this is really going to be another really exciting day. I wanted to welcome you to the Johns Hopkins Children's Center, which is where you are sitting right now. And the vision in the Johns Hopkins Children's Center is that Johns Hopkins Pediatrics is really the birthplace of modern pediatrics, which is true, and also the future of pediatric health care. And I think we all know that the future really depends that all children are healthy. All children are healthy and grow up healthy, have the care that they need, have access to care, but grow up in healthy communities as well, and that they grow up to be healthy adults. I think there's growing research that demonstrates that there are early antecedents to adult disease. We need to make sure our children are growing up healthy, and that we need to make sure our adults are remaining healthy as well and all have equal opportunity. And I think that that's what this conference is all about today. We all are here in Baltimore, and we know that there have been challenges here in our beautiful city. It was Martin Luther King that said that the riots are a language of the unheard. Think about that for a minute, the language of the unheard. To me, I think that the unheard are the young people in our community, the young families in our community, as well as the adults in our communities that really are feeling like they are unheard. How do we make sure that they are heard and that we really provide the opportunities that we all need to thrive together? I think it's all up to us in this room to really create that future and to really make sure that the unheard are heard and that all the voices are heard so that we can create the future that we want for our children as well as for all of those, the adults in the community as well. So I really congratulate Harolyn and her team for really a wonderful program. Look forward to really thinking about solutions to the issues that we're facing today to make sure that we can eliminate the health disparities and that there's room to grow for all of us. Thanks.
Let's see if I can do this. So now it gives me great pleasure to introduce Sara Anton. She's an associate professor at Johns Hopkins School of Nursing. But first, I'd like to thank Dr. Szanton. She mentored one of our center program students about 2 years ago. He presented actually at the Room to Grow about the same time ago. And since that time, he has published 2 first author peer-reviewed publications, and now is in Lesotho as a Fulbright scholar examining community perceptions of national health reform. So this is really, really a great testament to mentorship at Johns Hopkins and how we reach out nationally to our students in the community. So Dr. Szanton's talk is entitled Decreasing Health Disparities with Older Adults, the Capable Studies.
Good morning. I'm really happy to be here. And Dr. Chang just made me think of another Martin Luther King quote that's always been a favorite of mine, which is that the opposite of love isn't hate, the opposite of love is indifference. And I think that's really deep. And here we all are trying to make a difference. So I was a lobbyist before I was a nurse. So I see the healthcare world in terms of public policy terms. I went to nursing school after being a lobbyist, taking nurses around Capitol Hill, helping them talk to their congressional, staff, and really deeply listened to what they were doing and thought, wow, that sounds like a lot more fun than being a lobbyist. After nursing school, I worked with migrant workers in rural Pennsylvania. And this is not the people I worked with, but to illustrate that I've always worked with people where housing was tenuous or challenging. And after working with them, I worked with homeless adults here in Baltimore at Healthcare for the Homeless. And after becoming a nurse practitioner, I worked with homebound older adults who were indigent. And so really have a visceral sense through decades of the ways in which housing impacts health. And in our current health system, we tend to reimburse for things like inhalers and, drugs and procedures. But we're starting to move towards a much more inclusive way of looking at social determinants of health, which include housing. So we're going to be talking about that a little bit today. This is Mrs. B. She is a particular person. She also represents a lot of some of the social determinants of health. She is sitting in a chair, and feel free to come around if you want. She's sitting in a chair in what used to have been her dining room, but she can't go up her stairs now. So at some point, a family member had moved a bed down into her dining room. She spends pretty much the whole day in that chair, not by choice, but her legs are weak. She can't stand long enough to prepare food, and she can't get dressed very easily because this is her closet. You can see it's safety pinned together, and it's really just a sweater bag. But there's no closets in dining rooms, usually. And she has hypertension, congestive heart failure, arthritis, and diabetes. Very common in older adults, commonly go together. But each one of these has kind of interlocking disabilities that can come from them, and are all in a way socially determined, or at least socially modified. Back to her, you can see she's got her medications on her bedside table, and so that's her front door there. In terms of strengths, she worked all her life. She has a grown grandson who's a truck driver, and when he comes through Baltimore, he fills her fridge and her freezer with food. But the first time I went to see her, I brought just some nuts and some fruit as a little present, and she ripped it right open and ate it because she's hungry, because the things that she knows to cook take a fair amount of standing at the stove. Now we changed that over time, but this was her at the time that we met. And this is her floor after we filled it in. She had holes throughout her floor, and that would be dangerous for any of us in this room, but as you get older, you walk a little bit more shuffly. These are stairs that would be dangerous for anyone. These are her back stairs. So I mentioned we filled the holes in her floor, and you would think, well, how do you do that, as a nurse, or how did that work? And so that's the story I'm about to tell you. But before I do that, in case there's anyone who's not bought into the cause and they care more about economics, or in case you're thinking about how do you sustain a different way of looking at health, I want to walk you through this chart a little bit. So, am I allowed to move? Can I move? Is it okay? So this is for you statistics nerds, relative risk of one. This is kind of the average spending of this blue line. And you can see that as you start to have some chronic conditions, your healthcare spending, which is what economists call it, goes up, meaning, you're more likely to live after one. But these steeper numbers are when you start to need help with things like bathing, dressing, grooming, walking across a small room, things we call activities of daily living. And so those constraints are what cause a lot more healthcare utilization, but we ignore them in typical healthcare. If your parents or grandparents go to a doctor or nurse practitioner, they may be asked, have you fallen recently? But I can pretty much guarantee you they're not asking, can you stand long enough to cook? Can you get your leg over the bathtub to get into the bath? But those are the kinds of things, as you can see, that drive healthcare costs. And obviously, older adults care about getting dressed and getting bathed, right? Perhaps more than they care about their hemoglobin A1C or other kind of medical control. So based on my work as a house call nurse practitioner and seeing all these housing challenges, and also on work that Dr. Laura Gitlin had done in Philadelphia, we developed a program called Capable. It's Community Aging in Place, Advancing Better Living for Elders. And we focus specifically on people's strengths, their resources, their goals, about what they wanted to do in their daily life. So just as an example, when they pick goals with a nurse and they pick goals with an occupational therapist, and they're very specific and functional. So it may be, I want to be able to get down my front steps and into my daughter's car so that I can go to church, so that I can go to the grocery store, so that I can do something in the community. It's not, I want to get my blood pressure to a certain rate, unless that's what their goal is, and then we support that. So they get a handyman, a nurse, and an occupational therapist for 4 months. And together, the whole thing costs a little less than $3,000, and about half of that, a little less than half of that, is the home repair and modification. And I'm going to tell you, so just to outline this talk so you're not impatient, I'm going to tell you how the program works. Then I'm going to show you some data of what we've shown to improve people's health. Then I'm going to tell you a couple stories for individual patients so you can see how it works. And then we'll talk about how we're using this to work on health disparities. And also, I'm happy to have questions anytime throughout, so don't feel like you're going to off-track me if you have any questions. So it's a 4-month program. We collect people's data at the beginning and at the end, and that is not with the nurses and the OTs. That's with data collectors who are asking standardized kind of questions about depression and pain and healthcare utilization and disability. Then the occupational therapist, are there any occupational therapists in the audience? Yes. Usually I can tell because they're nodding like this when I'm talking. But, okay, great. Occupational, at least in the adult world and the preventive world, occupational therapists are really underused and under-recognized. And occupational therapists are about the function and about fit between the person and their environment. Am I right? Okay. So in our program, occupational therapists do make the first 2 visits to a person's home. And in the first visit, they do an assessment of every single ADL and IDL. That means, do you have difficulty bathing? Do you have difficulty dressing? Do you have difficulty managing your medications, preparing food? And then for each one, the person says if they care, if they have difficulty, and if it matters to them to work on. So someone may say, yeah, I can't do that, but it doesn't matter because my daughter sets up my medications in a little box and I take it every day. I don't want to work on that. But what I really want to do is to be able to take out my own trash or hang up my own laundry. I'm always surprised by some of the things that people want to be able to do, but it's their life, it's their home, and it's motivating to them. So at the end of the visit with the occupational therapist, they've come up with 3 goals. And again, it might be, I want to be able to stand at my dishes and stand at my sink and do the dishes. I want to be able to come downstairs. We have many people who are trapped either just on their first floor or just on their second floor. They want to be able to use their whole house, for example. On the second visit, the occupational therapist goes around the house with the participant and looks at how the person interacts with whatever part of the environment they need to do that goal. So if what they wanted to do was to get down their front steps, they will go out together and watch how the older adult tries to do that. Or if what they want to do is take a bath themselves, because currently what they have to do is wait till their grandson's around to pull them up out of the bath, which I guarantee you no one wants to do, either the grandson or the grandmother. They'll watch how, where she's strong and the size she is and what she grabs onto. So then together they make a work order for the handyman. And it's based around their goals that we were just talking about, what they wanted to be able to do. And it's a combination of home repair, like filling in the holes in the floor, home modification, which is things like putting up a second banister on a set of stairs, or assistive devices, things like something you can put on your toilet to make it taller so it's less hard to get off of, or risers you can put under someone's bed to make it taller so it's easier to get off of. And then the handyman gets in there pretty soon, within a week or 2, and can do everything that's in that budget in about a day. Then the nurse starts, and the nurse also does an assessment of the domains that the nurse is working on, and that's pain, mood, communication with a primary care provider, strength balance, and anything around medications. If they're on 4 blood thinners, for example, which we've found before, if they don't understand their medications, if they can't afford their medication, if there's too many, if there's too few, anything around medication. And so, for example, and if you just ask someone, are you in pain, a lot of times they'll say no. But this assessment is really pretty detailed. So does it hurt when you bend to get down into your dresser drawer? Does it hurt when you reach up to grab something? So the pain assessment is very functional. Then the nurse and the OT pretty much alternate, and what happens is that for the goals that they pick 3 goals with the occupational therapist and 3 goals with the nurse. They work on 1 goal per visit, where the older adult themselves says, well, maybe I could do this, or maybe we could try this, and then the clinician uses their clinical knowledge to support what the person's talking about, because maybe they have an idea based on their clinical experience. But there's none of it is our goals, and none of it is like pushing them towards a certain outcome. And again, I'll tell you a couple stories of patients so you can see how that works. Here's a visual representation of the work that we do. This is the same house, before and after, and it's hard to believe, but 2 85-year-olds live in this house. And they were living without any kind of banister for the last 4 or 5 stairs. And if you've ever had just a leg injury or anything, you know it's pretty much impossible to get down without holding on to something if you're a little bit weak. You can see we always try to put in 2 banisters, 2 important stairs, because then someone can distribute their weight, on all 4 limbs, and that makes a big difference. This picture also shows you we don't do anything cosmetic. And so those are unstained, and the participants always understand that. So far this has all been tax dollars, and we say that, and they often have a neighbor or someone who can stain things or paint things if they want that. So we are getting towards the end of a large randomized controlled trial with NIH funding of our project, and the people are randomized to either receiving the services I've just been talking about or other services that I'm happy to also talk about. We also had a large CMS Innovation Center grant, and in that group, it's a 1-arm trial. And we have a comparison group of people who we've never met, and I'll tell you more about that. And the data you'll see will be from that 1-arm trial. We also have a series of trials in Michigan, in Flint, Detroit, and Saginaw, where they're looking to see if in people who are already nursing home eligible, if they get capable as an extra service, would it help keep them out of a nursing home longer. We have colleagues in these other places that are also either doing capable or about to start it as well. So as my own mother says, why are people doing this before you have the results of the randomized controlled trial? And I say, thanks, Mom. But we're building on top of prior work, and it makes a lot of sense, and we have a lot of great preliminary data as the answer to that question. This is a map of Baltimore, and you can see that except for the quite wealthy areas that are in the light purple, we have people all over the city. And in fact, word of mouth has been one of our best recruitment methods. So here's some data. This is from the 1-arm trial. And let me just orient you. So so this is the number of ADL difficulties someone has come into. The average about 4. So that could be they have difficulty bathing, dressing, swimming, walking across a small room. And the red line is the average. The black lines are each person. And you can see that we're just about cutting in half the number of ADLs that have difficulty bathing. It's really pretty unheard of in the older adults. Some people do get worse. And that makes a lot of sense because it's over time, and these are quite low-income older adults. And so some people have strokes, some people have heart attacks. Things happen. This is why you need more than 5 people in your study to show. And so over time, you would expect that people would stay the same or decline. But so the fact that so many are improving is really very exciting. And another way of looking at the same data, and this is from Health Affairs published about 2 weeks ago, the green is the percentage of people who are improving. So this is about 75% improvement over time, which we're just thrilled about. And you could say that staying the same would be really doing pretty well also. And then this is the IELs, the things like managing medications, shopping. Oh, thank you. I'm sorry. Wondering. It's on? It's on? Okay. Depression, so we're not giving an antidepressant, but this is about the same improvement as an antidepressant. And you can imagine, if you've been sick for a week or longer, or not been able to do what you want to do for a week or longer, it's depressing, right? And so as people become able to do what they wanted to do, to get down their stairs, to take a bath, to get dressed how they wanted to, people's moods are lightening, and we see it, and it's very exciting. After about the second or third visit, the nurses and the OTs, they come back and they're so excited to see. It's just people seem brighter. And this is the same kind of model for depressive symptoms and home hazards. You can see that even for people who weren't depressed at the start, this includes everyone who didn't have any depressive symptoms to start, so that more than 50% improve on depressive symptoms. And of course the home hazards are improving, but we concluded that anyway. This data shows you that essentially people have the same slope of improvement whether they've been hospitalized recently or not, and that hospitalization is a marker of frailty and of vulnerability, and so this isn't just the very well people that we're improving. And in fact, before I tell you a couple of stories, part of the way that this is a health disparities story is that so 85% of our sample were African American and 80% were women. And every segment, we cut our data every possible way, by age, by race, by gender, by were they depressed at the beginning, by every way we could count. And there was no difference in the slope of change, meaning people in general got better no matter who they were. And we believe that that's because it's so tailored, right? We're not coming in and saying, you have to move this, and you have to do this, and I want your hemoglobin A1C to be this, and I want your blood pressure to be this, and you got to take these medications. It's entirely wrapped around what each person wants, and what each person wants is very different. And we can't predict it as healthcare providers. We can't say, I know you're going to want to do this, right? It's all about what they want to do, and we use our clinical knowledge and our experience to support what they want, but that's very different than coming into someone's house and telling them what to do. And so we believe that that's why we have such good results across the board, no matter who we are helping or who we're working with. So I'm going to tell you about two participants. So Mrs. D, she was actually the first CMS participant we had. We'd already started the NIH trial. And both our occupational therapist and our nurse came to me after the first visit and said, I don't know, I don't think there's anything we're going to be able to do for her. She is really out of it, just kind of slumped on a commode chair. And I really think she probably needs to be in a nursing home. So, the researcher in me thought, oh no, we've included someone who doesn't fit the inclusion criteria, and what are we going to do? But we just said, well, she's in our sample, and we're just going to work the program and see what happens. So it turned out that she was on 26 different medications, and many of them were for pain, and she took them all first thing in the morning. So she was just really out of it. And she was religiously good at taking her medications every morning. She knew they were important. But what we did was the nurse drew up a really nice medication calendar with suns and moons and afternoon signs and big letters of what each one was for, and could help her see that she'd been taking some multiple things that she wasn't supposed to be. And once she started taking the medications the way they were prescribed, she was like a partially different person. She was much more alert. She was aware. And also, for those of you who are into self-efficacy, it was an easy win. It was a quick success. She thought, wow, these people are really going to help me. This is making a difference, And so we build on that, and that's part of what Capable does. So as an example, on the first OT visit, we help them see how to get it from a fall, even if they haven't fallen. If they have fallen before, we go to where they were in their house and what the situation was, and we show them. A lot of people don't know some basic things about turning to their side first and getting up, but that's another example. We're always trying to build on little easy wins where they're saying, oh, wow, I could do that. Now I'm not as scared of falling. So with Mrs. D, she was unable to get out of the bed herself, and it was quite a low bed, and she was a large woman, and her husband was a very frail thin man, and he would just pull her up out of the bed and plunk her, which was the best he could do, on this commode chair. And for those of you who aren't medical people, that's like a toilet with a closed seat. So one of her goals was to get out of the bed herself. And you know, we all take that for granted, that we can get out of the bed ourselves. But this was one of her goals. Another one was to be able to get down the stairs and wash her hair in the kitchen sink. And to me, this is such a good example of why you ask other people what their goals are, because that wouldn't have been my goal. You know, when I heard it, I thought, what's wrong with the upstairs sink? I mean, I'm sorry that I was judgy, you know, in my mind. I certainly didn't say that loud. But it's such a good example of why you let people choose their own goals. And so and this note about 30 minutes to walk to the bathroom. So she lives in a pretty typical Baltimore row house, and the width of it is about from here to that other podium. And it took her, the bathroom was there and her bedroom was here, and it really took her 30 minutes to walk that length. And then the stairs were there. And so she hadn't been downstairs in a year because she didn't have the stamina. You know, she sat all day. She didn't really have this, I mean, she had a walker, but she by the time she would get to the top of the stairs, she was completely exhausted. And so she came up with her own, when we were doing the brainstorming and the action planning, she came up with the idea of putting small plastic deck chairs, like you would get from Target or something, along the way, so that she would use her walker and sit for a while and recover. You know, for no one in this room would you need to recover from walking 2 feet. But she did, and that's how she built up her stamina. And so in the month between the OT's first visit and second visit, she built up the stamina to be able to get to that other podium, you know, to get to the bathroom. And by the end of the study, it still took her 7 minutes to get that far, but that's totally different than 30 minutes. We elevated her bed with these little $7 risers and put a really strong grab bar on the side of her bed. And the first time that she got out of the bed herself, her husband burst into tears. He was so moved that she could do this for herself and that this had been what she had wanted, and also that he wouldn't, you know, be pulling her out every day. And so these are tiny things. Look, if you think about what I'm just saying, they're both tiny and profound, right? So it's deck chairs. It's a $7 risers. It's a second railing on her stairs so that she could get down when she wasn't exhausted. But it's also really profound, right? She's not sitting on a toilet all day anymore. And 2 months after she had finished with us, her granddaughter called us and said that she was going to Atlantic City. And this woman hadn't been out of her, contributing to the economy, right? So she was more extreme in terms of how she started and how she finished than some of the other participants, but I think she does a good job of showing us the potential for, you know, if the OT and the nurse who work with me on their first visit thought, I don't think we can do anything with her. Most people would have thought that, right? Because if they thought that, and they have all this training and about the resilience of older adults, and there's no throwaway people. And people are resilient at any age, and at any, except for the last month of life. People, their muscles can get stronger. If they get some easy wins and they can brainstorm what they want to be able to do, there are just no throwaway people. Everyone can improve. And the thing with aging is that unless you have a calamity, you know, like a car accident or a stroke or something where you suddenly get a lot more services, most people who are older adults gradually age and gradually adapt. Right? And so you start to get shorter than your shelving, for example. But you don't think, oh, all of a sudden I need to rearrange this, right? If you had suddenly had something where you had to be in a wheelchair, you'd get all these services, they'd come to your house, you'd get rehab, but aging is very gradual. And so for someone like Mrs. D, you know, she ended up just sitting on that commode chair all day. She had never decided, oh, this is how I'm going to live my life, you know, but it had gradually started, but a program like Capable can come in and support older adults to work on their goals and change to become more resilient. I'll give you another example. So we had Mrs. H. She had asthma, diabetes, hypertension, and arthritis. And she was unable to get dressed or take a bath really because of breathlessness. She had asthma that was fairly bad, and she was only on a rescue inhaler rather than a long-acting inhaler. She was also in a fair amount of pain, but she didn't take what she thought she was supposed to take, which was Aleve, because it hurt her stomach. And for those of you who work with older adults, there's classes of medications you're not supposed to take as an older adult because they do hurt your stomach. So she wasn't taking anything. And she couldn't hear well, even sitting in the second row of church. She couldn't hear the pastor, and this was very depressing to her. The community mattered a lot to her. So we did some very small things. One was we connected her with her original primary care provider. In that first nurse visit, one of the things we ask is, do you like your primary care provider? Does he or she pay attention to you? Do you feel like you can ask him or her questions? Is he or she hard to reach? And those questions often they elicit, oh, great, it's perfect. But sometimes you hear, no, he or she's slapping me on antidepressants, or no, I'm not really getting hurt. And we can either help them advocate for themselves, or sometimes we help them go back to a primary care provider they liked more, or pick a new one. We also have a lot of house calls, primary care providers we can refer them to. But so in this case, she got back to her original one that she liked, and she got on the longer acting inhaler, so she had more lung capacity to be able to do what she wanted to do. We also just suggested Tylenol instead, which won't hurt your stomach. She started to take that. She was in less pain. She started to do the exercises that we have, which this is a woman has taken the booklet and pasted it to her closet, which I'm very fond of, so she can refer to them to do her exercises. But they're based on Tai Chi and Otago, which are core muscle strengths at fall prevention. We also gave her something called a super ear. I don't know if any of you have heard of that, but it's about $35, and it's about the size of an iPhone, and it has earbuds that go in your ears. And she wore that in church, and actually around home. I went to her house, and she was wearing it to talk to me, and she loves it. So these are tiny things. We also, she had, her linoleum floor was curving up a lot in her kitchen and in her hallway, which was a trip hazard. So all of these things are tiny, right? Just like Mrs. D, Tylenol, a $35 super ear, the right medication, but together they made it so that she could hear, she could be engaged, she wasn't in pain, she could take a bath, and it turned her from someone who was too breathless and unable to take care of herself to someone who's out and about in the community. And she actually looked right in my face and said, if I had 10,000 tongues and they could all speak at once, I couldn't praise the Capable program enough. Because she felt like it really gave her life back. And she's appeared in videos for us, and she said, I'll do anything you want. So what we've talked about is that, remember that slide with the spending, that poor function is costly. Older adults really care about it. It's virtually ignored in medical care, and we've already shown just now that it's modifiable. So why aren't we doing more of it is the question. And this is what she said to me. So in terms of health disparity, and don't you like these happy patriotic people? This is a funny electoral season slide. But so in terms of health disparities, I'm sure you all have as many ideas as I do, but I do, and I am a big believer in population health as well, not just doing things one at a time. And my other stream of research is about the ways in which food stamps affect health. So of course we need to change social determinants partly from a macro side. But in terms of the lessons we're learning from this Capable work is that everyone is individual, right? It's pretty obvious. But even though there are socially patterned problems of health inequity that arise from things like structural racism and differential access to the job market, that when you are an older adult who's had that life experience, there's no one to give up on, no one to throw away, right? And that we can work by addressing what motivates them and what they want to do, and then supporting them by things like working on their house and themselves. Anyone can improve. And older adults, people often joke, are our only natural growing resource, right? There's 10,000 people turning 65 each day. And many of those are well and volunteering in the schools and doing all kinds of stuff, but some of them are like Mrs. B. And any of them, I think, can benefit from at least one visit of trying to understand what someone wants to be able to do, what they need to do to adapt to do that. And we have people continually say to us things like, I'm 80 and I didn't realize I could get better. Or I'm 85, I didn't know I could have goals that then I could achieve. Or people say, people teach you how to be a kid. They teach you how to be an adolescent, but no one teaches you how to be old. And this kind of problem-solving mentality of what would you like to be able to do, and then how can we do it, is applicable across all kinds of people. We are scaling and starting to scale capable into all kinds of ways of paying. And for those of you who aren't up on, healthcare reform, basically until the early George Bush years, pretty much all of medicine, except for things like Kaiser Permanente, were based on the more visits there were, the more procedures were, that's how providers got paid. And in the Bush years, and then really accelerated by the Affordable Care Act, it's starting to get switched, where whole organizations start to get paid for people being healthy rather than being paid. Right now, hospitals need people to have heart attacks and need people to get asthma attacks and need hip replacements. But as that starts to switch, where they need them to be healthier from a financial perspective in the community, there'll be a lot more openness to thinking through, okay, how do we do that and how do we support that? So a slide that I left out because we haven't published the data yet, and we're webcasting this and you all can have all these slides, is in the CMS trial that I mentioned, that's the one-arm trial, Maryland Medicaid has matched each one of our folks that we have with 10 other people who are their same race, age, number of chronic conditions, zip code, and healthcare utilization in the year prior to our people spending. So if there's one person, then Medicaid has gotten 10 people that matches them in all those attributes. And we've looked, so we haven't met those other 10 people. We haven't assessed them ourselves. We haven't looked at their houses, for example. But just in terms of healthcare costs, what they've done this analysis for us and shown that we are decreasing inpatient hospitalization and nursing home utilization by enough that it pays for our own person to get capable and 2 other people in the same year. And so once we are able to publish this and show, and that's just to Medicaid, and Medicaid is not the primary payer for older adults, Medicare is. So it will probably be at least double that if you put Medicaid and Medicare together. So if a payer can be saving $20,000 in a year by paying for capable, which is $3,000, we think that there'll be a larger worldview that payers start to have of, oh, if we give someone another banister, this might help, right? They don't have to do capable, but just this wider view of keeping people healthy, I think, will start to have some impact. So I think we have some time for questions. I want to acknowledge I've had a lot of generous funding and wonderful co-investigators and a fabulous team. Particularly, I just want to give a shout out to CivicWorks, which, if you're from Baltimore, it's in Clifton Park, and they are a huge job training site with AmeriCorps funding. And they have a high school, they have a free farm, they have all kinds of things. But one of the things they do is they train people to do home repair. And so they are our handyman. It's a young apprentice plus, their mentor. And so we always have 2 people who go in, one of whom is paid for by AmeriCorps. So, yeah. Is it okay? Oh, good. Oh, yes. That is a wonderful point. So, right, so client-directed, we call it client-directed instead of client-centered because with this whole era of the patient-centered medical home, I'm sure some places they're doing it really well, but in other places, what it means is the patient's in the center. We still tell you what to do, but it's just more convenient for you. And you're just at the center of everyone telling you what to do. So we call it patient-directed because it's their goals. Then to your question about, is it hard sometimes to the clinicians not to jump in or not to problem solve for them? Absolutely. And in fact, if, CMS has the ability to scale capable as soon as we show that it saves costs, but it would actually be really scary if just overnight they did, and I know they won't, because it takes a little time to train the OTs and the nurses for exactly the reason you're saying. It's very common in the beginning for them to say, well, what about my goals? Or when do I check their blood sugar? Or, and no, they've got primary care, that's not us. And it's not about our goals. It's about their goals. And I think part of it, I think you mentioned, is not jumping in right away. So, if you say, we've talked about a lot of things, you want to try to come up with 3 goals, and then you just have to be quiet. Right? And you can remind them of what they said were problems, but it is so hard. And when we train other people, like in Michigan, for example, if we role play, of course, everyone hates role playing, but it's very effective and efficient. They'll just jump in right then. Well, you said you're in pain. Let's work on pain. And so it takes a while. And so what we end up doing is supervising people very closely for their first 6 months or so, because they'll be reporting about a participant and they'll say, so I told her, and then she said, but then I said, but I told her she'd better. And you just think, okay, so do you hear what you're saying? And so absolutely, that's tough. And hopefully over time, clinicians will be trained more about motivational interviewing and will be trained to not just be hierarchical in terms of, I have all this knowledge, you're an empty vessel, you have a problem, I'm going to solve it. Which mostly comes from good intentions, I'm sure. We all go into healthcare because we want to help people. But there's better and worse ways of helping people, I think. Yeah. Great. So the question was, how did we deal with people with cognitive impairment? And we mostly excluded them. So in the CMS, so they were both, because it's so much about action planning and coming up with your goals, and we at first excluded them. And in the NIH trial, an NIH protocol is like a cookbook, like you can't vary from it. And so that we never touched. On the CMS one, they considered that more quality improvement, and we could change things as we went. And so for a brief period, we did include people who had a mini mental down to about 18, which is fairly cognitively impaired. And so then we had a proxy, someone who worked with them. So we actually ended up having, it was interesting, we would have 2 different goals, for example, the proxy, what they thought were the goals, and then what the participant thought. And we had some great successes. We had someone who had fairly severe dementia say at the end, I feel like me now. And we also had some cognitively challenged, people who had been cognitively challenged their whole adult life. But what ended up happening was just logistically, we hadn't been set up for it. And so we had people, who were in like a daycare all day, and we had to do evening appointments, or their caregivers were so stressed that, they were a working job, and they would come home, and the last thing they wanted was for an OT to be like, what are your goals about your mother? And so we ended up going back to just cognitively intact older adults. But I think there's a lot of promise based on what we saw. Yeah.
Thank you. And I was very pleased to hear your mention of population health. A project of this magnitude has a great potential for community capacity building and sustainability. And I was just wondering, have you thought about the use of community health workers?
Yes.
Especially as you scale it up.
Yes. So the question was about, you have a nice loud voice, but about if we thought about involving community health workers. We have, and in fact, we are working with a group called AgeWell that was started in South Africa, but it's coming here. And what they do is they get at the area of social isolation for older adults and also readmission. So they have older adults who are trained to be AgeWells, who have a algorithm of questions that they ask the person they're working with, and also they just kind of hang out with them. And so those questions might be things like, did Comcast leave wires across the stairs, which happens incredibly commonly, or is there food in your refrigerator, those kinds of things. And then based on the algorithm, there's a risk score for the person, and also they just provide companionship. So we've looked at two ways of working with the AgeWell program. One would be that some of our capable participants become well enough and want to contribute enough that they would become an AgeWell volunteer. So they go through capable first, and then they would become one of those community health workers. The other way is the flip, where when an AgeWell would, let's say, visit with someone who'd been recently released from the hospital, that the algorithms could say, oh, you would benefit from capable. So I think there's nice models for that. Sorry, I'm not seeing it. Whoever has your hand up, go for it. I don't see you.
I was just going to say, one of the, and I don't know, typically in grants, I'm sure it's not a measurable determinant, but I think one of the key things in this wonderful program is the socialization. I mean, all human beings need it, but the socialization and having people know that somebody is going to come and visit me and be there. And then I would think what it does for the caregiver, if they have a caregiver, to know that they're not totally responsible. Like, once these things are in place, people become active again and want to be able to help themselves. So I think it just has such a nice balance, but it's so important because, you know, in aging, well, for everybody, but in aging, they show, you know, the key determinant is socialization.
Right. Well, so two things to that, and thank you for your kind words. Two things to that. One is, I didn't mention what our control group gets. They also get 10 visits, and they make their own goals about what they want to do, but they're sedentary thing. Right? We couldn't make it exactly the same, or we wouldn't be comparing two groups. But we were worried or interested to see how much of the effect is actually that you know a nice person is coming to your house who cares about what you think and is helping you achieve your goals. And if that is the case, and we can do that we actually have a community health worker who does the other arm, then great. You know, if we can decrease healthcare utilization, you know, if it's as good as capable, then that's much more sustainable, right? So that is the control group, and we'll know the results of that in April. And then to your other point, we had one of our early participants was someone who had Parkinson's disease, and she shook badly enough that her food went everywhere as she tried to eat it, and her goal was to feed herself. And her caretaker, her family member, said, oh, you'll never be able to feed yourself. I don't think that you shouldn't waste a goal on that. But as occupational therapists know, there are weighted spoons that are just about pretty much take away that problem. And the just deep joy on her face when she could feed herself without getting her food everywhere was just so moving. And sometimes caretakers don't know what's out there because they're just human beings like us who got thrust into a role that they weren't, you know, educated for. So, yeah. Right. So the question was, do the participants have to own their own homes? And if not, how do you get permission, basically? So they don't have to own their own homes. So a number of them are living in their daughter's or son's home, and that's pretty easy. Some of them do have landlords, and in fact, we had a couple in, Baltimore Housing Authority housing, but we haven't had a single landlord yet who says, "Oh no, don't fix my house." So we have had a couple of landlords who were shamed into doing it themselves. But what's interesting, right now we're doing a pilot with modification of capable specifically about social isolation in people with end-stage renal disease, people on dialysis. So you may or may not know, people on dialysis, their kidneys have failed, and it's a very rough life because they have to go to a center for multiple hours, and on the days that they're doing that, they're exhausted from all the fluid being taken from them, and the days they're not there, they're exhausted because the toxicities are building up in their body. So we noticed from doing capable that some of the people who just happened to be enrolled who are on dialysis, now they could get dressed and go where they wanted to go because they weren't as fatigued. And but the reason I'm saying that in response to your question is, in our pilot with people on dialysis, none of them have owned their own homes, and so it's been a much more. There's just a lot of waiting involved with the land because you have to get them to sign something saying it's okay. But that's been different for us.